Thanks very much, Soph, and to the organising committee. It's a great honour to be asked to present here some cases of how I manage patients through Ramadan. I'll just tell you a little bit about my background. So I grew up in Turkey, and I know the cultural things that happen in Turkey are quite different to what happens in Australia, and it's very important to emphasise that Muslim patients are all very different, and they are also, I suppose, under the there's a more of a cultural background that they bring into the consultation. So, for example, in Turkey, what I mentioned is that when I was growing up, that patients with diabetes were expected to fast. Over the time, that has changed, and we have to respect patients' wishes, and it's really great to see that in your guidelines that you'll mention that the religious leaders would encourage, if there's any concern for medical safety of the patients, not to go ahead with the fasting. So these are patients that I've managed recently in the last 18 months or 2 years. So one of them is a 59-year-old man who has had type 2 diabetes since 2004. He has had obesity, hypertension and dyslipidemia, and has had depression as well. He was commenced on insulin in 2010. This is his medications. He was on aspirin, metformin, 1,000 milligrams twice a day. He was on dapagliflozin, 10 milligrams Erbisart and 300 milligrams. This is just taken straight from his medical record, antidepressant, and he was on insulin 36 units twice a day with Novamix 30 and Vytorin as well. So he was referred to me because of poor glycemic control with an A1C consistently above 10%. And when I examined him at the time of the examination, his BMI was 37. He had weight of 102 kilos with multiple skin tags, acanthosis nigricans and central obesity. His blood pressure was 140/80, had dual heart sounds, no carotid bruits, peripheral pulses were present, and the sensation was intact, had no ulcers. In terms of his social history, he had a suboptimal diet and suboptimal physical activity. He was a non-smoker and teacher, and he lived with his wife and daughter. He was unwell, and there was a lot of stress because she had brain cancer and was having treatment for that. So review his HbA1c results preceding really 2 years prior to the appointment showed readings of HbA1c above 10%. The time of the visit, his A1c was 10.7%. He had albuminuria as evidenced by a high ACR. Total cholesterol was 4 millimoles per litre, LDL was 1.9 millimoles per litre, triglycerides elevated 3 millimoles per litre, HDL cholesterol is 0.95, and his estimated glomerular filtration rate was greater than 90 mils per minute per 1.73 metres squared. So it's obvious that the issues that of significant insulin resistance and poor glycemic control. He was initially in the long term quite interested in bariatric surgery. So we also discussed Ramadan, and he, at the time of review, we discussed his insulin dosing. So I suggested that half of his insulin dose to be given in the morning. So from 36 units, he took 18 units in the morning with sahur, and he took his usual dose in the evening of 36 units with the iftar meal. And I emphasised that it was very important for him to check his blood sugar levels 4 times a day, and there's a very important misconception that you are not supposed to check your blood sugar readings, and that was very important to discuss with patients, that they should check their blood sugar readings, and that's allowable, as well as insulin being given during the time of Ramadan. So, and he had instructions to break the fast if his blood sugar was less than 4, and to keep well hydrated during the time when he was able to eat. And we actually continued him on the Forxiga, dapagliflozin, and we discussed the potential risk of dehydration, and he was to take it after his dinner, which he did. So he actually did pretty well. He didn't have hypos, and he didn't have to stop his fast, although he didn't bring his blood sugar records. He brought his glucometer, and we had to look through that, and we just reinforced the need for this for next time. And just in terms of Ramadan, that went well for him, and I'll be seeing him again this year. But in the meantime, he actually went ahead and we organised for him to see the bariatric surgeon, and he had a laparoscopic sleeve gastrectomy, and we discussed before the decision weight loss and diabetes benefits, possible use of insulin post-operatively if necessary, and he was initially assessed for obstructive sleep apnea prior to the surgery, and had his bariatric surgery, came off his insulin, and actually he's lost about 15 kilos since, and he understands if glycemia deteriorates post-operatively may need injectable therapies. This is his more recent reviews, 93 kilos, and his A1C did come down for the first time in about 3 years, down to 7.9% with the weight loss, and he was off on insulin, on metformin, and that's what he's taking at the moment, along with his antidepressant and his Vytorin. So, so he's generally happy, as he doesn't need to use the sleep apnea machine and as many medications, and he's not on insulin, and he's encouraged to increase his physical activity to avoid adding other medications for diabetes and hypertension. So that was him. So should we discuss his management?
Elif, I might start, but this is aside from Ramadan, interesting choice of antidepressant, meclobamide. I guess the psychiatrist can't be persuaded to use another agent because this one tends to elevate blood glucose levels quite acutely.
Yeah, he did see a psychiatrist. He actually saw a Turkish psychiatrist because of the language barriers, and he had tried some different antidepressant agents, but I might have to bring that up with him. Yeah.
Maybe that's the only one that works. Dr. Papa, sorry? Yes, sorry. I've forgotten your name. It's,
My name is Majid. I'm from Iraq. So, how do you classify this patient prior to Ramadan? I mean, his hemoglobin A1C was 10, and he's on premixed insulin. So, is he among categorized as high risk?
High risk, yeah, high risk. And he didn't have macrovascular complications, but he's a high risk patient. But the problem is that he had significant insulin resistance, and unless we went really high on high doses with insulin, it was going to be difficult to get his blood sugars down.
The question from Jane in the middle.
I've got a very loud voice, so I should be okay. Jane Overland from Prince Edward Hospital. I actually want to ask you about the bariatric surgery and whether you've had a number of patients have that procedure and what impact that may have during Ramadan.
So he had the bariatric surgery after Ramadan, so we'll see, because we'll be able to see that soon. But he actually, his glycemic control improved post-bariatric surgery, but his still A1C is still high, so this is on metformin, so he's presumably still quite insulin resistant, but he'll lose more weight.
You're alluding to hypoglycemia post-bariatric surgery.
But he won't.
Yeah, I'm just wondering, if anybody that's had bariatric surgery, because there are an increasing number of patients having that procedure, and whether that actually needs to impact on our recommendations.
Yeah. He didn't have bypass. He had the
sleeve.
Yeah.
I think it's a very good point. The number of people who have bariatric surgery is increasing. We haven't really accounted for that in the guidelines, but we should. Obviously, it depends on what type of surgery they have and what sort of complications it have, if anything. The most important one would be the postprandial hypoglycemia, because then they will have hypoglycemia at a different time. But during the fasting hours, I don't expect them to have many symptoms. One other point in Ramadan, some people feel a bit of nausea, and many post-bariatric surgery have nausea anyhow. So it's one of the things that we need to consider in bariatric surgery patients, or whether the level of GI symptoms is high or not, and whether it increases during Ramadan or not. But it's an area that we will need to understand more before we start giving recommendations.
Question down the back, sorry, could you? I should say. Yeah.
I noticed that your patient is on the mixed 30. Just wondering whether you have any experience using like a mixed carb 50 in these patients who are on large meals during like 2 meals a day, and then in the middle they're actually not eating anything for lunch.
Yeah, I think it's an important point, but I suppose they had limited access to myself and the diabetes nurse educator, so for that instance, and it was coming up quite close to Ramadan, I didn't change his insulin, but it's possible to do that. It'll be nice to do it before Ramadan to get a sense of stability. Yeah.
And we'll discuss that in the next section as well. Tang, did you have a question? Yes. Comment? No, sorry. We'll try one more time.
Thank you. What about using Novox in this patient? Because you continue to use high dose despite two facts. First, he has poor control diabetes with hemoglobin A1C above 10. So we expect it to deteriorate more. That's one. The second, there is a risk of hypoglycemia. What about switching to Lantus and Novoradid instead?
Yeah, so for two reasons why I didn't do that. I don't, to be honest, I don't find long-acting insulin like Lantus to have any effect postprandially. I mean, patients do have very high blood sugar readings after the meal, so unless they're going to be on sulfonylurea, then that doesn't really help the situation, I find. So I actually find Novamix 30 postprandially improves blood sugar readings, and these people have significant insulin resistance, so if they have a carbohydrate, large carbohydrate meal, their blood sugar, I mean, Lantus has got, no, sorry, it's very difficult to bring the sugar down with just prandial insulin.
But we can use Novoradid for the
Sure. Absolutely, and I mean, for this patient, that was the other option. Like, he could have gone on to basal bolus insulin. I met him, his A1C was consistently above 10. He had seen another specialist about bariatric surgery previously and didn't come to that decision. And then when I met him, we had the discussion. Actually, I think surgery has helped the situation.
Dr. Park?
Can I ask you, with insulin-resistant patients post very high carb, high GI food, do you see much in the way of that dumping or hypoglycemia-like symptoms that troubles patients afterwards?
No, to be honest, I haven't, and like not unless it's early on in the disease when the beta cell, may not be functioning as well. But when they have diabetes, I find that it's hard to control it, and the only thing that's helped in that situation is either surgery or SGLT2 inhibitors, in my experience. And the other thing that's helped is agents like the DPP4 inhibitors, in addition to the mixed insulin. Would you agree?
Absolutely. Yeah. We might move on to the next case.
Okay, so this is another case another man who I also met the last 18 months, I think 2 years. He's a 62-year-old man. He actually had long-standing diabetes and was reasonably well controlled until more recently. His A1C, when he was referred to me, was 8.4%. It was diagnosed 2007 following total thyroidectomy, and he had fortunately no microvascular and macrovascular complications. And he was well controlled on metformin and diamicron. And for some reason, the GP ordered a routine lactate level, which was 2.6, and the upper limit was 2.2. And so he had no symptoms at the time of acidosis, such as nausea or vomiting or feeling unwell. He actually did have a lower leg infection and may have been hypovolemic. He had no heart failure or renal failure. And at that time, he was taking metformin, 1,500 milligrams twice a day, so it was a large dose. So, and his GP ceased his metformin, and he remained on diamicron, and then he was referred to me to commence Byetta. That's just outlining his past medical history again. So he had 10 years of type 2 diabetes. He was quite careful with his diet and had whole meal breads, ate mainly home-cooked meals, and was able to exercise quite regularly. He was ex-heavy smoker and stopped about 11 years ago, had no alcohol intake, and had 4 children. And he actually had a taxi driver's license, but he wanted to maintain, not that he was working, but he wanted to maintain that, and that was the other reason for seeing me. His father had diabetes, but there was no family history of premature cardiovascular disease. So when I saw him, his BMI was lower than the first gentleman. His BMI was 30, weight was 92 kilos, 176 centimetres, blood pressure's well controlled, 120 on 80, cardiovascular examinations unremarkable, and his peripheral vascular examination was unremarkable. So what I did in that situation, I thought that the high lactate was in the context of a high dose of metformin and hypovolemia and possibly infectious. So we just started metformin 500 milligrams twice a day, and he was to call me, and that all went well. And then when I saw him, he was on 500 twice a day and the diamicron. And then it was around that time when I had to give him advice about Ramadan. So he was on 120 milligrams of diamicron and 500 twice a day of the metformin. And he stopped after discussions regarding Ramadan, we stopped his sulfonylurea and commenced him on DPP-4 inhibitor, and also increased the metformin dose. So I just increased it to start him on 50 of sitagliptin twice a day, along with 850 of the metformin, and he was to take it with iftar and sahur. And these are his other medications. He's on Lipitor and Prindapol, and aspirin at the time is Tolopram. His HbA1c was 7.7, and he did well. There was no issues really during Ramadan. Blood pressure's 135, and we discussed more advice regarding lifestyle measures. And eventually he was on maximum dose of metformin with the diamicron, and he failed the DPP-4 inhibitor, and now he's on Vigerion. And that's where he's at the moment. I'll see what his HbA1c, it was 7.2 when in that using that combination, so that's working well for him.
You've got very complicated patients, I guess we all do, with depression.
Yeah, so I was thinking of trying to choose a simple one, but they all had...
I guess it's not easy every day. Okay, we've got time for some questions. Jane.
Sorry, it's me again. I mean, there's this tendency for us to use these slow-release sulfonylureas, and I wonder whether during the period of Ramadan we'd be better off using one of the shorter acting sulfonylureas. Is that something that you would recommend?
I think Mohammed's going to present on this, but I think there is some evidence that diamicron MR has been compared with sitagliptin in one of the trials and had the lowest risk of hypoglycemia during Ramadan. So
it wasn't clear in the study whether it was MR or gliclazide. In some countries, they use MR. Sorry. So in some countries it was gliclazide. In other countries it was MR. But the data could not differentiate between which is which. But because of this precise question, we're planning a new study for next year. Maybe we can include Australia as one of the hubs as well.
And we don't have the meglitinides, which some countries have. And are they used fairly commonly in the Middle East?
They're not commonly used, but when they were studied, because of the short acting and the fact they're prandial, it showed good response in Ramadan. Because you can adjust the dose based on the mean size.
I mean, we certainly use that in our steroid-induced diabetes, where we've got that hypoglycemia over, 8 to 12 hours, and then dropping low overnight. So I just sort of see that as, perhaps being a similar model to Ramadan, where you've got your two very large meals that are occurring over, say, 8 to 10 hours.
Eddie?
Just a question on the raised lactate. Obviously, approaching Ramadan is a period of risk of dehydration and hypovolemia. Did you monitor his lactate at all during the fasting period while he was on metformin?
no, I didn't, and he wasn't acidotic at the time when the lactate was measured, so I think that was just a furphy, to be honest. He's tolerated it well.
So
it's possible that if he develops heart failure, and he may be prone to it, but his lactate level wasn't that high. I'm not entirely sure why it was checked. There are some GPs who, I'm not sure, you might be able to answer this, but was it common practice to ask patients to have random lactate levels at any stage 30 years ago, or do you remember? Sorry, Stephen?
John?
Yeah. Were people on metformin?
Sorry.
Occasionally I come across these patients where the GPs requested lactate levels if they've been on metformin. Was it practice in the past to measure lactate levels at any stage?
I don't remember what happened in the 18th century, but certainly in recent times, no. And only to add that there is a lack of relationship between lactate and metformin dose anyway. There's stuff being done at St Vincent's that looked at people with renal impairment, and there was no relationship between the dose and lactate levels. So my view is that it's useless to measure lactate routinely when somebody's taking metformin.
Eddie, do you measure lactate levels at all?
No, I was just curious about using metformin during periods of prolonged fasting, whether that should prompt any further, look at that.
Probably not.
No,
Yeah, I think it's pretty well tolerated after the meals. I did have a question about SGLT2 inhibitors because I was worried about, whether they would lead to dehydration or thrombosis. But it's great to see there's some research underway on that topic. And then the other thing is just to emphasise that people with diabetes can check their blood sugars and can have insulin, so even when they're fasting. So there is this misconception amongst patients, like during the fast, like the day.
So I guess again it depends on the cultural background as to how large the meals are and how they're eaten. So in Malaysia perhaps one might need to double the insulin dose in the morning. I'm not sure. So, but here clearly there was a decrease in.
Yeah, I reduced the morning dose,
Yeah.
but kept the same dose of the dinner dose.
Okay, just wonder if you noticed in your cohort of patients they might have a rebound phenomenon prior to iftar, and you might have an artificially high readings.
Prior to iftar, generally that's probably the lowest. Well, they're supposed to be lowest during that time because they've had the long.
Some of them anecdotally, and they do tend to drop their sugars, but as we expect, around 4 hours, just late in the afternoon before iftar. And if they don't check that time, they will have a rebound. By the time they come to iftar, the sugars are falsely high. And that might prompt the clinician to increase their morning Novamexol.
Oh, right, yeah.
So it's
Okay.
something I've noticed in this
Yeah, yeah.
What about their physical activity levels during Ramadan? Was that increased or was that at the same pace? Or?
Well, I think culturally, I think it's more of a time for family gatherings and meals, so I would think it would decrease, apart from the praying times. But generally, it's all about good food. Feasting. I have to say the food is really good, but it's full of carbohydrate, really high in carbohydrate.
In moderation.
Hi, I'm Penny, I'm a diabetes educator in Hornsby. Just a question, do you have any specific comments about patients on insulin pumps through Ramadan, apart from the obvious ones of not bolusing when they're not eating?
Yeah, I think maybe it's because I'm Turkish heritage and I see a lot of Turkish patients, but I must say I haven't had that many type 1 patients be in that situation. There is obviously the need to reduce the basal rate to, I would say 50% during the day, and then maybe have higher insulin during the meals. So I think it's flexible, and that's what I wanted to emphasise, that you can have insulin during the day if you have type 1 diabetes. That's no problem.
Can I just say, we've just finished a study, a weight loss study doing the Guide 2 approach, and using guidelines about Ramadan and OptiFast guidelines to reduce basal insulin by 50%. I can tell you now that is excessive. It only needs to be reduced by about 10% on fasting days, and I would presume it would be quite similar. I'll be interested to hear the guidelines from IDF. But
and we will hear about that.
Find you'll have significant hypoglycemia.
Okay. So Mohammed, perhaps that's something you covered during your talk as well. Okay.
Yeah, no, I mean, I think the issue is that you don't want to break a fast because of a hypo that, yeah.
Great. Okay, thank you very much for
thank you.
sharing your expertise.